Okay, and I was just going to talk a little further about what kind of trials are envisioned for SIREN. So we went in with an application that really set out not just an infrastructure, but a sort of vision for how we were going to do things and why we were going to make things better. And we set out some design principles that we'll go over briefly. We'll talk a little bit about the scope of the portfolio that's been tasked to us, and review briefly where we are with the pipeline and the network right now. So this is the slide you saw earlier, and I just want to reinforce the elements on it. The focus really on early treatment, because really that's what we offer to the world that we didn't have before. So the emergency setting is a really challenging place to do clinical trials, and creating an infrastructure that actually has boots on the ground and knows how to work in that environment and make things happen in that environment was really what we offer the clinical research community that wasn't there before. So that's part of the design, that we're going to really focus on the pre-hospital space, the emergency department space, even the early critical care space. Those divisions we don't see. So we want to get rid of those barriers. We don't say, something has to happen in the pre-hospital space and we're only working in the pre-hospital space, so that's no good if you're in the ED. The patients, the diseases don't respect the barrier of hospital to ED, ED to ICU, and so we want to be able to span those barriers. Focusing on meaningful outcomes for patients, we really want to make people better, right? So that's the key. And so in NET, we were tasked with specifically only being able to do phase 3 interventional studies. I think that we've broadened out as long as we can stay to that core mission of figuring out ways to make people better. We can delve into the exploratory space a little bit if it's part of a clinical trial development program. But those are really key parts of the principles that I want to go over again. Design principles was a big part of the vision of our application. So one of the things that we found lacking in a lot of other enterprises was the ability to find the design, the clinical trial design that answers the most important questions. So people have a way of doing trials, and people do traditional trials, or they do adaptive trials, or they do pragmatic trials, and they sort of have their sort of niche of the way of doing things, and then they always bend the question to fit the way that they like to do things. And that has, I think, led to a lot of failed trials in the past. And so what we really said is that we want to have a network that will find the appropriate tool, will find the appropriate trial design to answer the appropriate question. And even trials that we've done, we can go back and say, gosh, probably we didn't ask the question as well as we should have. So we participated in the ATAC trial of intensive blood pressure lowering in hypertensive acute ICH patients. And there was no difference between the two groups. And we sort of had this band of more intensive control and high intensive control. And when you sat back at the end of the trial, and maybe you could have done this at the beginning of the trial, you said, the question really wasn't, is this range better than this range? The question was, what blood pressure should I target? And that was a range of targets, and we could have designed a trial that actually found the blood pressure that was optimal. And that would have made a lot more sense, except that it wouldn't have been an A versus B standard clinical trial. And everyone always says you have to do that. You don't have to. There are ways of using more innovative trial designs to answer the right question. And we can go through, when we get to the pipeline, some examples of what we've done for that. The other tool on the one end of the spectrum then is the trials that NET has done, which are well-controlled efficacy trials with smaller numbers and very intensive high-quality data collection. There's been a big push, and NHLBI in particular has been very interested in these large pragmatic trials. Is a term I hate to use because it means so many different things to different people. But we thought that there are some questions that come up that are better answered through something like a registry-based randomized clinical trial. And so one of the innovations that we did was we reached out to some of the groups that had large registry databases like AHA and the American College of Surgeons, and said, are you interested in developing randomized controlled trials that can be implemented within the context of your registry? So the registry is already paying for outcome data collection and a lot of baseline data collection, a lot of what you would collect in a clinical trial. And they were very interested. They don't have the randomized clinical trial experience. They do have the registry-based experience. And so getting together with them when that's the appropriate question. So when you've got a question that is answered by the outcome data that are already being collected in this registry, that needs large numbers, that doesn't necessarily need tight control, then that might be the right methodology for that question. So we try to put more quivers, more tools into our belt so that we can use the right tool for the right question. We also spend a lot of time on clinical trial design, thinking of ways that to make the trial mesh with the clinical care that we're providing in the emergency setting. So if it's too hard to do the trial, then you end up with trouble with implementation. If trouble with implementation leads to lack of enrollment, you end up with a very skewed sample. You get poor quality, and this is something that FDA has been pushing for a long time, which is quality by design. If you design the trial appropriately and integrate it into clinical practice, you'll get better quality, better answers, and that's an important part of success that takes place right at the early design phase. So I just want to talk a little bit about the scope of the portfolio. So we have been tasked, as I said previously, with just doing phase 3 late intervention trials. But one of the things that we've realized is that a lot of times a study idea comes and there's not enough data necessarily to know how to design the correct phase 3 confirmatory trial, and there's still a need for a phase 2 trial, and I again hesitate to use phase 2 because that's been used in different ways, but I like to think of that still as the learning phase, right? So phase 2 trials is a state where you're going to do more exploration through a range of questions, and phase 3, confirmatory phase, where you're going to try to narrow down on the final answer. As long as we're in a therapeutic development process and it looks like what we're doing in a phase 2 trial is answering the questions that we need to answer in order to implement the phase 3 trial, we do see that as part of our mission. So late phase 2, things that are merging into it, maybe phase 2, 3 seamless trials, are definitely part of SIREN's scope. We've already talked about patient-oriented outcomes. In terms of efficacy trials versus effectiveness trials, we do see that as all of our space. So we are interested in well-controlled trials. We're interested in very pragmatic trials that answer clinically relevant questions in a way that is implementation focused. Those are all within our scope. We do want trials that are appropriately sized for our scalable network, so that the SIREN has this hub and spoke network where we can do smaller trials, or we can gear up by adding spokes for the appropriate trial to make a much larger network. But it does need to be within our scope. So if it's something that's really a single or 2 institution study, there's really no reason. We don't have that much to offer so that would be too small. If it's something that requires many more hospitals than the network can provide, that's less good for our scope. That's a less good fit. There are ways of doing that, so we have collaborated with other networks and found ways to do trials that have required many more sites, but ideally it's appropriately sized for our scalable network. In terms of the mission, clearly we are funded by NINDS and NHLBI, and we have agreed that the primary focus of the network going in is going to be on neurologic, cardiac, lung, and blood trials. So that is no doubt our primary focus. That's what we want to start with for sure. That's everything that we're going to talk about in the pipeline is in that focus. That being said, from a visionary standpoint, we are perfectly willing to envision expanding that to other emergency focuses and other institute centers' portfolios, health services research, as long as it doesn't interfere with our primary mission, our primary funders. So that is in our future, I think. Talk a little bit about the trial pipeline as it stands. So really going to talk about 5 projects that are in the stages of either having been funded, approved, or grant applications that have been submitted and are awaiting review. and they're Hobbit or Hobbit, either is correct. Boost 3, Icecap, chest pain, and hat trick. So Hobbit is the hyperbaric oxygen brain injury trial, and this is a trial that's been in one form or another developing for even longer than this. Work began on this particular version of a hyperbaric brain injury trial in 2014, and you'll see that a lot of these have somewhat long lifespans. The PIs of this trial are Galen Roxwold, Bill Barson, Byron Gajewski, and Renee Martin. It's a phase 2 trial evaluating 7 different dose tiers for hyperoxia in severe TBI. It's expected to enroll about 200 patients. It's got a very interesting primary outcome, which is because this is a predictive trial to determine whether it's worth going on to a phase 3 trial. It's a Bayesian primary outcome that looks in the predictive probability of being greater than 50% that there will be success in a phase 3 trial based on the signal of efficacy in this earlier trial. And the trial will select the most likely effective dose tier to carry forward into that effectiveness trial. So this trial went in before we knew that there was going to be a SIREN, right? So this trial, started in 2014. The application went in during the end phase of NET before we even knew that there was what the RFAs were going to look like for SIREN, and we knew that this is what we wanted to do next. That being said, so it hit the ground. It got approved for funding at the same time that SIREN did, so we were able to make this the first SIREN trial. But that's why this starts so early in SIREN's history. Boost 3 is the brain oxygen optimization severe TBI trial. This is a phase 3 trial to determine whether management strategies based on brain tissue oxygen monitoring plus ICP monitoring compared to ICP monitoring alone improve outcomes after severe TBI. So this falls off of a phase 2 Boost 2 trial that was done outside of the network that showed that there is significant unrecognized tissue hypoxia when you put in brain tissue oxygen monitors but don't look at the values compared to when you look at the values, and that by knowing the values and recognizing that tissue hypoxia and treating it, you can improve outcomes. At least that was the trend that was shown in the phase 2 trial. Again, this trial goes back to working in 2015 before SIREN existed, and the application went in while we were still unaware of who was going to be the SIREN Coordinating Center. So this developed sort of in parallel. Funding has been approved for this trial and is anticipated sometime soon. Icecap is the influence of cooling duration on outcoming cardiac arrest patients. This is a trial design that we actually were working on in NET in cooperation with the Resuscitation Outcomes Consortium, and that we actually designed during a planning grant phase called the Adapt It Project, which was a planning grant that we had to develop adaptive clinical trial designs for use in NET as a sort of experimental laboratory. This is a good example of the adaptive trial designs that we were talking about. So this was a case where we were saying, what's the most interesting question of dose of hypothermia after cardiac arrest might be duration, because we can make it shorter or longer. It has the ability to compare, to discover the duration response curve for the duration of hypothermia and cardiac arrest. And by showing a positive curve, that has the ability to answer the question, does hypothermia work at all? Because if there's a positive dose response curve, FDA has used that as a surrogate evidence when you can't do a placebo-controlled study of efficacy. So it can answer that first fundamental question. And then it can answer the next question we want, which is, if hypothermia works, we think that there's about a 50% response rate to it. Can we get a better response rate to that therapy by using a higher dose, a longer duration? And so this is the case where we could have done what traditional trials have previously done and just chosen a random longer dose and said, well, okay, people are usually killing people for 24 hours. Let's compare it to 48 hours, which is what a recent European trial did. But just having those two groups would be a simple way to design it. But at the end of the day, you just know about those two durations, and you wouldn't know whether a third duration was better or worse or not. You wouldn't be able to define the curve, because you really can't define a curve very well with just two data points, because it can look like all sorts of different things when you just go through 2 points. So again, so this was this adaptive design that we can answer the question of what is the optimal duration. And we can use part of the panel time to talk about that more if you want to know what that design is exactly. Chest pain, on the other hand, is the comparative health effectiveness of strategies testing pain assessments of ischemia non-invasively. And this is really the opposite. This is really that study that looks at, it's a non-inferiority trial comparing in-hospital non-invasive testing strategy versus outpatient testing in patients with low-risk chest pain. This is the kind of study that has a simple, straightforward question that is A versus B, and what you really need are just tremendously large numbers to look for a very small difference. And so this is a conventional study being designed in an environment where we can try to get massive numbers of this very common illness in a very standard way. So the thing that you'll see about both these two trials, so these Icecap and chest pain are both trials that just went in this year after SIREN, and these were the first two SIREN submitted trials. And this was a conscious attempt to try to balance our portfolio. So we already had these two TBI trials, these two neuro trials that had been developed prior to SIREN. So to balance it, we really wanted to have some cardiac trials, and so now we've got two applications in pending review there. HETRIC is a dose-finding trial of TPA in patients with submassive pulmonary embolism, and this is a planning grant that's being submitted to come up with that adaptive trial design that answers the important question. So this is, and this is Dr. Klein's study, and if people want to know more about this, we can talk about it during the panel discussion as well. But it's really using that adaptive strategy to find out if we can answer the question of whether TPA works, and if it does work, does it work better than placebo, and if it does work, what's the right dose? And so try to answer more questions than just one question. And if the trial is a neutral trial, make sure that it's a neutral trial that is informative, because one of our mantras is that a negative trial, a neutral trial, is not a failed trial. A failed trial is a trial that doesn't answer the question. So if it's a trial that answers the question, that really proves that it's neutral and that tells you what you need to know, that's great. If it's a trial that just tells you that you didn't do it right, and then that's really a negative trial. So that being said, there's the pipeline for the network is robust. We get lots and lots of already, lots and lots of people interested in lots of different ideas, and they come to us with different ideas. If you ever saw the movie The Player with Gary Oldman, he sort of gets stopped every 15 feet, and somebody pitches a new trial idea. It's sort of like Jaws meets Alien, and we get a lot of that. It's sort of like the Toast trial, but anyway. So there's lots of different ideas in discussion. We move them along as quick as we can. There are bandwidth issues, so sometimes we don't get back to things as quickly as we'd like. But we're always developing and always trying to keep things in different stages of development so that we'll be busy all the time. And our website is siren.network. You can always go there and get more questions answered.
All right.